So let me now introduce our esteemed speaker. So Mr. Jibril Farah is a consultant neurosurgeon and clinical lead at the world-renowned Wharton Centre. He specialises in functional and stereotactic neurosurgery, epilepsy, movement disorders, neuro-oncology, degenerative spinal conditions, and I'm sure a lot more. He was appointed in 2008 and on the GMC Specialist Registrar since 2007. He also directs the fellowship programme at the Wharton Centre, and in 2023 joined the NHS England Clinical Reference Group for Neurosurgery and Spinal Services. And I'm sure that's only the tip of what he does. We're incredibly lucky to have you here tonight, Mr. Farah. I know you're extraordinarily busy. Giving up your time for the cavernoma community is very much appreciated. So I'm going to hand over to you now.
Thank you very much thank you very much for the opportunity of presenting and sharing my experience with cavernoma-related epilepsy. Okay, thank you again very much for this opportunity. What I'm going to talk about tonight is the management of cavernoma-related epilepsy. What is really the patient selection, and what are the surgical indications, when to consider open surgery, and when to consider LITT, which is a relatively new adjunction to our therapeutic instrument to treat cavernoma-related epilepsy. This is Liverpool. We are in the northwest of England, and this is our hospital. We are one of the possibly only lasting self-contained neurosurgical unit and a neuroscience center, and you can see us on a map. Let's start with a very brief introduction. So what is a cavernoma? Cavernoma is an abnormal cluster of blood vessel, mainly capillary, located in the brain, spinal cord, with a tendency to leak and bleed, and with a tendency, if they are supratentorial, to cause epilepsy or single seizure. The incidence of cavernoma is between 0.15 to 0.5 per 100,000 inhabitants. The anatomical location is variable. This talk will focus on supratentorial cavernoma. Supratentorial cavernoma will cover nearly 80% of all cavernoma. Posterior fossa cavernoma are a slightly different type of pathology, including brainstem cavernoma, and only 5% will cover spinal cord cavernoma. The bleeding rate for cavernoma is variable and is between 0.6 to 11, is cumulative per year. There was a study looking into the bleeding rate of cavernoma and found that was possibly between 3 and 5% cumulative per year. But again, cavernoma being capillary will rarely cause a catastrophic bleed, and there will be nearly all the time a seepage of blood with an hemosiderin ring around the cavernoma itself. Cavernoma are familiar, nearly 50% are familiar, but they can be sporadic, and there are a few genes that have been located and identified. When cavernoma are familiar, generally there can be multiple cavernoma, with sometimes in the range of 20 or 30 cavernoma in one single individual. And here is a picture of a cavernoma, and as you can see, there is a cluster of capillary. Generally, there is a small artery on the surface, and then you will have a draining vein. Draining vein is quite important for the surgeon. Is a DVA, is a developmental venous abnormality, which is associated with cavernoma, and generally needs to be preserved in the vast majority of cases when a surgical resection is considered. And again, this is a picture of a cavernoma. Cavernoma can be in the supratentorial compartment both superficial or they can be deep-seated. The vast majority of cavernoma causing epilepsy are superficial, and the cause of the epilepsy is generally related with the irritation to the cortex. Less frequently, deep-seated cavernoma, for example, this picture, abyssal ganglia cavernoma, are causing epilepsy. The more superficial are generally epilepsy-related cavernoma. As I said before, this can be single, multiple, familiar, or sporadic, and this is giving some degree of heterogeneity in the nature of cavernoma themselves. And here you have a picture of one single cavernoma, a quite large cavernoma, or an MRI scan of a familiar multiple cavernomatosis, in which you can see there are several different cavernoma of various size. In the case when the epilepsy is related with multiple cavernoma, then there are additional difficulties in identifying which one of the cavernoma is generating the seizure. In the vast majority of cases, generally is one single cavernoma, but could be difficult in those cases to identify exactly the one which is causing the epilepsy. What are the surgical indications for cavernoma, and when cavernoma are really dealt by a neurosurgeon? There are two main indications. One is the risk of bleeding, and the risk of bleeding, as I said, is stratified in the range of 3 to 5% or even more in some series per calendar year cumulative. But generally, this leads to an increase in size of the cavernoma, increase in size of the hemosiderin ring, and is very rarely a catastrophic bleed. But indication to do something on a surgical point of view is a cavernoma that is increasing in size with repetitive episode of bleed. The other indication to treat cavernoma is seizure-related, so epilepsy. Again, cavernoma can present, and generally will present, with one single seizure, and generally this can be controlled with one single medication, but there is a minority of patients in which the single medication or multiple medication does not really control the seizure, and in those cases, patients are generally enrolled within what is defined as an epilepsy program, and the indication to actually resect the cavernoma is related with the frequency of the seizure themselves and the drug resistant. We are going to talk about cavernoma and epilepsy, as I said beforehand. Epilepsy related to cavernoma is a lesional epilepsy. In other words, the cavernoma itself with the bleed, the hemosiderin, the mass effect irritate the cortex and generally cause the seizure, and is the actual focus of the epilepsy. There have been several studies looking at which component of the cavernoma is generating epilepsy. Generally, is not the cavernoma itself, but is the bleeding and the hemosiderin ring which is around the cavernoma. In a specific case in which you have epilepsy which goes on for several years, you may have one single cavernoma which is causing seizure, and then epilepsy-related changes within the temporal lobe with kindling of the hippocampus, and in those scenarios you have what is called dual pathology. One of the things that needs to be considered in cavernoma is the risk of SUDEP, sudden death related with epilepsy. This risk is in the range of 1 in 1,000. And that is particularly relevant for patients with cavernoma, one single seizure, which are then controlled on medication. And in reality, the potential risk of SUDEP is not eliminated by the fact that the individual is well controlled on single medication. When we are looking at patients that are treated in my practice and in our epilepsy program, we are talking about patients with cavernoma and chronic partial epilepsy, disabling, which are drug resistant, and naturally they are surgical accessible. In other words, it's possible to do something on a surgical point of view without causing any significant and long-lasting deficit of damage. Patient within the epilepsy program and then patient with cavernoma with epilepsy are enrolled in what is defined as an epilepsy surgical program. What we are looking in the epilepsy surgical program is, in the first instance, concordance. So the concordance is nothing else than looking at the seizure semiology. So what is the seizure itself? Is it a temporal seizure, extratemporal? In parallel, we perform what are our neurophysiological study. Neurophysiological study will include EEG, video EEG generally, in order to actually localize the focus of the seizure. So the aim of concordance is to identify the focus and actually saying, okay, is the cavernoma which is generating the seizure, and the area where the cavernoma is the area where the seizure are generated. Imaging, MRI scan, PET and SPECT will help in a different manner. The MRI scan will actually enable us to define the cavernoma itself and the anatomical location. The PET and the SPECT are more epilepsy-related imaging, which are utilized to confirm the hypothesis that the cavernoma in question is generating the seizure and the area nearby the cavernoma is generating the seizure itself. Other investigation will include fMRI scan, DTI, and VADA test, which is utilized rarely. The fMRI scan mainly is utilized to look at the hemispheric dominance, which is quite important in the decision-making between an awake procedure or an asleep procedure. The DTI will look at the tract and how a cavernoma can actually be resected. The non-invasive investigation, as I said, may lead to a first synthesis. Number one, the cavernoma is not related with epilepsy. In this case, surgical intervention is not indicated because removing the cavernoma will not address the epilepsy. Or it's possible to go ahead directly without any further investigation into curative surgery, and the curative surgery could be either an open resection or potentially a LITT. When there are situational cases where it's not possible to reconcile the data, invasive monitoring is considered. And invasive monitoring is nothing else than phase 2 investigation or stereo EEG or placement of LITT. What it is. Practically is the implantation of electrode within the brain in close proximity to the cavernoma in order to look at the spread of the epilepsy. And this generally has a clear-cut hypothesis, and the implantation is tailored to the hypothesis. In other words, we are looking at the cavernoma and the potential spread of the epilepsy from the cavernoma into the nearby area. And naturally, each electrode will represent a specific question. You can see these are the electrodes that we implant for patient, and generally this implantation will consist of between 12 to 18 electrodes, and we track the epilepsy from the area nearby the cavernoma to the surrounding area. We utilize a robotic arm in order to place those electrodes, and we utilize a stereotactic means. In other words, the placement of the electrode is quite precise. And you can see here the electrode planning, and you can see the electrode placed and the various trajectory. This is an invasive procedure, but it's a very safe procedure with a risk of bleeding per electrode in the range of 0.01% in all the years, and I'm doing this procedure. Possibly I had one single patient with a bleeding complication. And here you can see again the electrodes which are placed within the brain. Generally, temporal lobe epilepsy related with cavernoma is investigated in this manner in our center in order to look at the spread of the epilepsy and exclude the possibility of a dual pathology. The answer at the end of all this investigation is the definition of the seizure onset zone and the irritated zone, and then the functional deficit zone. In other words, we are looking at the whole area nearby the cavernoma in order to define what is going to be the best way to actually achieve seizure freedom, because the resection of the cavernoma in this scenario is related with the aim to achieve seizure freedom. What are the options for a patient that has been through an epilepsy program with a cavernoma and drug-resistant epilepsy once the hypothesis has been confirmed? So the options are open surgical resection. And open surgical resection up to possibly 2015 was the only option available. I distinguished the surgical resection as a temporal resection and extratemporal resection. From 2015 onwards, there has been a new technology, which is the laser ablation, which is an option for all sorts of non-lesional and lesional epilepsy, and also for cavernoma-related epilepsy. These are two very different approaches, and there are specific indications to treat condition with one option or the other. In other words, those which are approached with open surgical resection generally are not eligible for LITT. The other thing that we need to keep in mind is that cavernoma-related epilepsy, if it's temporal, is linked with a very good outcome with a seizure control in the range of 80 to 90%. Extratemporal, in other words, if the cavernoma is located in the frontal lobe, if the cavernoma is located in the parietal or occipital lobe, or is located in the insula, cannot be, may have a seizure freedom which is less satisfactory than the temporal. The LITT for temporal lesion is comparable in result with very limited number to what we achieve with open surgical resection. So, which are the one that we actually elect to treat with open surgical resection? Generally, large cavernoma, so cavernoma which are above 3 centimeters in diameter. When there is a concomitant potential risk of bleeding in conjunction with the seizure risk, and when there is a dual pathology kindling. In other words, the cavernoma is causing changes within the temporal lobe, and you have the cavernoma generating the seizure, but then the seizure are also independently generated by the changes caused by the epilepsy within the temporal lobe itself. In this kind of scenario, surgical resection is indicated because the area that needs to be resected is larger than the cavernoma itself. Here is an example of one of the patients that I treated earlier on. This is a multiple cavernoma. Actually, this gentleman had 2 cavernoma, familiar, with drug-resistant epilepsy, and I approached in one single settings both cavernoma. He had a frontal cavernoma and a posterior occipital cavernoma. They were both independently generating seizure, and in this specific case, what we did, we put grids over the cavernoma itself. We did the recording, and we realized that both cavernoma needed to be tackled on a surgical point of view. Naturally, these lesions were treated in the pre-LITT era. Potentially, this case could have been treated with 2 different sessions of laser ablation. This is another case which I operated and I tackled on a surgical point of view. This is an insular cavernoma. As you can see from the size of the cavernoma, is above the 3 centimeters in diameter, deep-seated, and this cannot be really treated with LITT, and it was treated with a Transylvian approach and a resection of the cavernoma, achieving seizure freedom, which has been long-lasting. In this specific case, one of the questions that I had preoperatively was the role of the hemosiderin ring. And as you can see here, you have an hemosiderin ring, and generally this can be potentially the generator of the seizure itself more than the cavernoma. We actually did a resection which was extending into the hemosiderin ring, and as I said, we achieved seizure freedom. So large cavernoma and multiple cavernoma generally are not a good indication for LITT. What are the cases that can be potentially treated with LITT in cavernoma? Small cavernoma within 1 centimeter to 3 centimeters. All these cases need really to be evaluated within the surgical epilepsy program. In other words, if the cavernoma is generating the epilepsy, if the cavernoma causes drug-resistant epilepsy, then it's necessary to identify the cavernoma as the generator itself within a phase 1 and phase 2 evaluation. We normally exclude all cases of dual pathology, and this is done with non-invasive or invasive EEG. And then the patient can be potentially treated with laser ablation. How we do laser ablation and what it is laser ablation. First of all, we do laser ablation or LITT with the aid of robotic arm software, which enable us actually to define the trajectory, where to place the probe. Then the planning is executed by the robotic arm. Everything is a stereotaxy, and therefore there is an accuracy possibly in the range of 0.5 to 1 millimeter. We verify the position of the probe, and then we perform the laser ablation utilizing an intraoperative MR scan with a real-time thermography and ablation. And here you have all the different piece of kit. This is the robotic arm that we're utilizing. This is the CT scan of registration that you utilize with the frame. And you can see we define an entry point with a laser, and then we placed the actual peg which will hold the laser probe in the skull, and this is the holder that will actually accommodate the actual laser probe. And this one is the measurement of the actual introducer. We verify with a CT scan and a metal introducer that the trajectory is in line. In other words, we are exactly where we want to be, and we acquire an intraoperative CT scan to confirm that. And once that is confirmed, we insert the laser probe. And here you have an MRI scan with the laser probe in the area which we want to ablate. This is not a case of a cavernoma, but I didn't have any specific video of that. But I wanted to show you how it actually works. And you can see here on the thermography, the laser probe generating the temperature. You will see some number, 1, 4, and 2. This is a continuous MRI scan that will measure the temperature, and you can see we define a different area in order to look at the temperature itself, and focus on this number, 63 Celsius, which is the upper limit. And you can see the blue at the tip of the catheter, which is this area, which is progressively heating up and creating a small blob of temperature. And you can see the ablation on the color-coded. And practically, that is the laser probe, which is generating the temperature and is progressively destroying and ablating the tissue. And when it comes to cavernoma, those probes are within the cavernoma itself, and they are burning the cavernoma from the inside. And it's possible with this to actually shape the area of ablation, and it's possible to do multiple ablation. In other words, it's possible to move the catheter back and forwards, but sometimes also to insert a multiple catheter with different direction. And at the end of the procedure, you will have an ablation which is generally within the 3 centimeter. Why 3 centimeter? Because if we exceed that number, there will be the potential of perilesional swelling. In other words, there is a swelling around the area of ablation. In this specific case, if you put it inside a cavernoma, you burn the cavernoma, but you will have swelling around the brain. And here is another case in which it's possible to see the thermography software and how it works in real time. The swelling, why the swelling is important? It's important because generally this lesion, cavernoma included, will be within the brain. And if there is any sort of swelling around the eloquent area, it's possible to have a loss of function in the specific case. But here you can see again the temperature which is raising around the tip of the catheter, and progressively the lesion which is generated. The temperature that we are generating with LITT is in variable between 65 degrees Celsius. We reach actually 75 degrees Celsius sometimes. And as I said, we can withdraw the catheter or advance the catheter accordingly, and we can actually shape the actual lesion. At the end of the procedure, we remove the catheter, and what is left is just a tiny opening, which is sutured with one single suture, and the treatment can be done as a day case. Problem of swelling is present after treatment, and generally we prescribe steroid in order to reduce the swelling. Regarding the management of the anti-epileptic medication following the treatment, we generally give a course of corticosteroid which lasts between 3 to 4 days in order to minimize this problem. We kept our case selection within the 3 centimeters in diameter, and we didn't have any significant problem. Personally, I treated one cavernoma-related epilepsy, and we achieved seizure freedom. In this case was a redo. The patient was originally operated for a resection of a cavernoma with open surgery. There was a residual hemosiderin ring and cavernoma. We identify that the seizures were still persistent coming from the specific area within the temporal lobe, and we decided to ablate that with LITT. And the other interesting thing is that within 14 months from the treatment, we, number one, achieved complete seizure freedom, and then, and secondly, the hippocampus and the cavernoma were completed, were practically ablated completely, leaving to only a small gliotic area. LITT for cavernoma is relatively new. As I said, the first time that I've seen LITT has been in 2012 and was an experimental technique. Now in the US is more or less run of the mill. In the UK, there are 2 centers which are dealing with epilepsy-related LITT, epilepsy-related laser ablation, and is King's in the south and ourselves in the north. Pediatric cases are dealt by the pediatric unit within the UK. Having looked at the literature, there are not many papers on cavernous malformation or cavernoma and LITT. This one is quite interesting by Robert Gross, which has been a pioneer in this area. And he reported a total of 19 cavernoma, all drug-resistant epilepsy. They were all evaluated within an epilepsy program with concordance with stereo EEG, in other words, invasive monitoring in 16 patients of the 19 patients. All these cavernoma were in the vast majority temporal, and 13 frontal, 5, 1 parietal. Multiple cavernoma were not reported in the series, so they were single. They were generally single cavernoma, and this also emphasized the fact that temporal cavernoma are the one that generally cause epilepsy in the vast majority of cases. Of all these patients, he reported an angle 1 seizure control, 14 patients, and this was divided in an angle 1C, 90%, and an angle 1A, 10%. What does it mean? The seizure control from the beginning was achieved in 10% of cases, and in 90% of cases, there were a couple of seizures immediately following the treatment, but then after that period, the patient became seizure-free on and off medication. 2 patients failed and they were not seizure-free, and they reported an involution of the cavernoma in up to 83% of cases, but there was no resolution of the cavernoma itself. In other words, there was still residual cavernoma. And here is the picture that is reporting, and you can see the cavernoma. This is a cavernoma within the orbitofrontal gyrus, a classical location for frontal related epilepsy. And you can see the catheter, as I showed beforehand, entering the cavernoma. One of the potential risks that is related with the placement of the catheter within the cavernoma is the potential risk of bleeding. But generally, being this capillary, the risk of bleeding is quite minimal, and on the other hand, the thermal damage will cauterize the actual bleeding point, leading to an ablation of the cavernoma. You can see here on the post-coronal, the surrounding swelling. And particularly, I will emphasize the size of the cavernoma. This is a cavernoma which is within 1.5 centimeter in diameter. As you can see, the swelling bring the area of abnormality up to possibly 2 centimeters. So there is a periregional swelling. And then when you're looking at the follow-up at 14 months, you have an ablation, and you can see fluid around it, but still the scarring and a bit of cavernoma present, which has been completely cauterized and fundamentally shouldn't really generate any seizure. When you're looking at all the cases reported in the literature of LITT for cavernous malformation, a meta-analysis which look at all these case series concluded that this procedure is safe. There are post-ablation deficits, which are mainly related with the swelling in relation with the cavernoma itself. These are generally transient, and they advise consideration of observation versus open resection. In other words, continuous observation for those patients which are non-drug resistant. Consideration of an open resection should be given, and possibly I will put the dimension of the cavernoma as one of the factors. And they concluded that it's necessary to have more study, larger cohort of patients, and longer term follow-up. In other words, the follow-up at the present is limited possibly to 24 months maximum, and therefore there is the need to validate those results. To conclude, open surgical resection is a well-proven option and should be, in my opinion, the gold standard for the vast majority of epilepsy-related to cavernoma. When you're looking at LITT, I think this is an option. The number of studies are limited and we need to have more data, but definitely it's very attractive, the idea of treating it with a minimal invasive modality. It's very reasonable to treat small cavernoma in this manner. What I think is very important is that the cavernoma, if they are operated for epilepsy, should be really investigated within an epilepsy program in order to fully investigate the patient. And as I said, the size of the cavernoma is quite important, and I wouldn't treat with LITT anything above possibly the 2 centimeter or 3 centimeter in diameter. And thank you very much for your attention, and I will be very happy to answer any question if you have any question.
Fantastic. Thank you so much, Mr. Farah. That was incredibly insightful. If I could just ask you to stop screen sharing, that'd be super.
Yeah, sure.
Oh, thank you. I mean, as you said, it's wonderful to have other options available. And whilst LITT might not be appropriate for everybody, and you talked there about the criteria of intractable epilepsy, the size. I think for our community, given the limited options and how invasive neurosurgery is, to have another option is marvellous. And for those who don't know, it was only last year that this was commissioned on the NHS and made available to cavernoma patients. So we're very lucky to have you talking about this so soon afterwards. And great to hear you've already had a cavernoma patient come through and see you, and to hear the benefits of that. So thank you so much.
Thank you.
So what I'm going to do now is we've already had 2 questions come in advance. I can see 3 questions in the chat, so I'm now going to go through and read those. So to everybody, we're going to take questions now until 8:30. So if you have a question, please do pop it into the Q&A. I'll do my very best to get through them. Sometimes we have more questions than time, but we will try our very best. So the first question. A CA UK member has had one of their cavernomas removed from the right temporal lobe in January by Mr. Walsh, who's well known to many people at King's. This person had epilepsy before the surgery and was told it had originated from this area of the brain in the right temporal lobe. And he's asking, if the epilepsy could return and originate from this area again. So my understanding is he has multiple cavernomas. It was thought that this one was causing it in the right temporal lobe. So yes, what would your answer be to that one?
First of all, that is the concept of dual pathology. In other words, and dual pathology and multiple cavernoma. Generally, if there are multiple cavernoma, is one that is generating the seizure. It's possible that the patient may have dual pathology manifesting itself later on. In other words, the cavernoma which has been resected has caused changes within the hippocampus and the temporal lobe, and later on down the line there is a potential risk of seizure recurrence. But generally, if the patient is seizure-free within the first 12 months on medication, the probability of recurrence of the seizure become less. I don't think that the probability of seizure are related with the other cavernoma, but I think they are related with the potential changes within the ipsilateral temporal lobe. But the fact that they achieved seizure freedom, I think, was a success. And I think it needs to wait and see. But the probability is going to be low, but cannot be excluded completely.
Thank you very much. And just I'd say with all of these, Mr. I'm conscious you can't give advice specific to an individual. You can only talk in general terms, but we appreciate that general guidance. So the next question is from a parent of an adult child under the care of mental health services. And they're asking if you could be contacted for a second opinion to review imaging, because they're trying to identify the cause of their daughter's seizures. And this person is also asking whether you undertake court work as an expert witness, because they're in dispute with the mental health services team about the care that their daughter's receiving for their cavernoma.
I answer both questions. First of all, each one of the NHS services is open for second opinion, and a second opinion is really a right of each patient and each British taxpayer, and I will be delighted to consider a second opinion. Regarding the court work, I think that there will be specific neurosurgeon with an interest in medical legal cases that will be best placed to look at this specific issue. Regarding the second opinion, absolutely no problem. Either myself or any other epilepsy surgeon in the UK will be delighted to offer a second opinion to a patient. Regarding the court work, I think is mainly related with a specific group of individuals, and I'm not one of those.
Yeah, I'm conscious it can be very time consuming, and that is the kind of niche area, but thank you very much. So I'm now going to move on to the questions in the Q&A, and just to say, if you have one, please do put one in there. We've got 4 so far. So the first question is from a CAUK member. I have multiple cavernoma, it's the familial form, and I suffer often with epilepsy, even with taking several anti-epileptic drugs. During COVID, I had 1 cavernoma removed and I had 1 year of seizure freedom. However, now my epilepsy is worse than ever. Do you think it's possible surgery will be suggested again? And how can we find the correct cavernoma to remove if this is offered again?
So that is exactly what I imply at the beginning, that resection of cavernoma, single cavernoma, multiple cavernoma, should be evaluated within an epilepsy program. Now, in multiple cavernoma, sometimes it's difficult to identify the specific cavernoma, but naturally, the nature of the seizure can actually indicate which cavernoma is generating the seizure itself. So is this a frontal seizure? Is this an occipital one? Is this a parietal one? Is this a cingulate seizure? And where is the cavernoma? So if the patient has been seizure-free for a period of time with multiple cavernoma following a resection, then he should really reinvestigate it with a video telemetry, imaging, and an hypothesis should be made. In other words, can we identify in a non-invasive manner which one of the cavernoma is causing the seizure. Can we confirm that with invasive monitoring? So if the seizure have recurred, it's necessary to reinvestigate the patient within an epilepsy program. And an epilepsy program is not one single individual, it's not just the neurosurgeon, it's the neurologist, the neurophysiologist, the neuropsychologist, and all these individuals will contribute into the identification of the specific cavernoma. I remember one of the first cases that I've done when I was appointed was a gentleman with a frontal cavernoma. And what I did, I placed a grid over the frontal cavernoma. He had multiple cavernoma, I think 18. We identified that generating the seizure, we resect that, and he was seizure-free, and he has been seizure-free since 2009, I think. But sometimes you may have a different picture, but the fact that there has been a period of seizure freedom is very positive. And the question is why the seizure have recurred.
Yeah. Well, thank you so much. That's a really comprehensive answer, and lovely to hear of a success story with that individual who had that freedom. Yeah. So next question, this is actually one from the chat. My neurosurgeons are struggling to determine whether my cavernoma has calcification around it or a small bleed, which may have caused my seizures. Is there any way to tell for sure?
Could be difficult. But then again, if there has been a small bleed over time, it will become an hemosiderin ring. In other words, the blood may look like a bit of calcium, but then the blood will resolve, and what is left is the dark. So imaging can answer that question. So a delayed imaging. So if on the immediate is not possible to make a differentiation, then if you get a delayed scan, let's say, for example, 3 months, the calcium will remain calcium, the bleed will actually resolve.
Yeah, so you'd expect to see that change. Thank you. And just the person who raised the question before about familial cavernoma, they've said, I'm waiting for video telemetry. Should I be off my medication for the whole time of the video telemetry to get more accuracy?
Each hospital that offers video telemetry will provide the patient under the supervision of the neurologist a specific schedule. In other words, our schedule is generally a period of 2 weeks. And within this period of 2 weeks, you will have the medication which are withdrawn. So we start day 1, day 2 on medication, and then progressively the medication are withdrawn if seizures are not captured, reaching a point sometimes in which the medication are completely withdrawn. But the withdrawal of the medication during the video telemetry needs to be done under supervision, because naturally there is a possibility and the potential risk of a very serious epilepsy, a very serious seizure during the monitoring. So it's a bit of a balance of risk, and the answer to that is yes, the medication should be withdrawn if seizures are not captured, and should be done under medical supervision accordingly with the protocol of the specific hospital.
And that's really helpful to hear illustration of what a schedule could look like, them to follow the schedule from their hospital, but really helpful to have that explained how that can look. So next question, is it possible to to exclusively have nocturnal seizures if you have a cavernoma?
Yes, absolutely. Absolutely. Yes. Yeah. That is. Yeah.
And there's some great resources on the epilepsy charity websites about the many different types of seizures. So that's always good to have a look at. So next question. If my epilepsy is controlled by drugs, but my cavernoma could potentially grow again in the future, would it then be considered for surgery or LITT?
So this is a very, very difficult question in the sense that the vast majority of cavernoma, so if I look at the vast majority of cavernoma under my care, I would say that nearly 70% would be patient with one single seizure, controlled on medication, a small cavernoma, which is not increasing in size, or possibly is increasing in size in a minimal manner. Naturally, that doesn't fulfill the criteria of drug resistant, and therefore does not fulfill the criteria of for surgery, either open surgery or LITT. But then again, the potential morbidity are still present, and that is what I was mentioning regarding the potential risk of SUDEP or sudden death. The potential risk of SUDEP is present even if the cavernoma is the seizure secondary to the cavernoma are controlled with one single medication. Naturally, how much is that risk? Possibly, the risk is possibly 1 in 1,000 and could be even higher than that. But currently, the policy is that if a cavernoma does not increase in size and the seizure are well controlled, is not considered for surgery unless the patient specifically requests for the cavernoma to be removed in order to control the seizure. So there isn't really a clear-cut indication unless the patient wants to have the surgery and fully understand the potential risk of the surgery.
And I think you've given a good comprehensive answer there of all the factors being considered. So thank you. The next question is, and I think there may be a few people here who have probably got the same question. I've had drug-resistant epilepsy. For this person, they've had it for 40 years. I have a left temporal lobe cavernoma. My most recent bleed was last year, and I'm now being considered for stereotactic radiosurgery. When would LITT be considered? So I can imagine there's a few people thinking, oh, we've got LITT, but I've been considered for stereotactic radiosurgery. Yeah, how does that work out?
Okay, temporal cavernoma. Generally, if there are no specific medical condition and specific reason, are considered either for open surgery, an investigation within an epilepsy program. Stereotactic radiosurgery is an option, because it's an option. The long-term follow-up of stereotactic radiosurgery for control of seizure in cavernoma is not as clear as open resection. And regarding the consideration for LITT, the size is the most important component of that. In other words, yes, you can be considered for LITT, but the cavernoma needs to be within that size that I mentioned. It needs to be a small cavernoma. If a cavernoma has bled and there is drug-resistant epilepsy with it, possibly I would consider open surgery personally. Stereotactic radiosurgery is a very reasonable option, but I'm not familiar with a specific case, but yeah.
Thank you. So the next question, I have a single left parietal lobe cavernoma. I had my first seizure back in 2016 and had seizures every 2 years since. My most recent one was 6 weeks ago. Luckily, I don't suffer with seizures more frequently, but it does affect my life massively when it happens. I always need hospital admissions with my seizures, but I'm currently managed by my GP and not neurologists. In your opinion, having been watching and waiting for 9 years now, should I seek a different approach? Would I be eligible for LITT or even its removal?
Okay, this is a question regarding the seizure burden. So, as a surgeon, if someone says to me, I have 2 seizures per calendar year, then the seizure burden, by definition, is not a particularly heavy seizure burden. But then, on the other hand, the seizure burden for the patient is very different from what I perceive as a seizure burden. So this could be devastating for the single individual. My suggestion is that needs to be evaluated within the local regional epilepsy service. And the first step will be to get an EEG. Naturally, I fully understand that if someone has 2 seizures per year, then the probability of capturing the seizure during the monitoring is going to be very, very, very low. But then on the other hand, you can look into withdrawal of the medication and then trying to capture it. So there should be at least an attempt. Would I personally offer an evaluation within an epilepsy surgical program? The answer is yes, if the patient feels that the two seizures are significantly debilitating to be enrolled within the program. Being evaluated within a program doesn't mean that the individual is signing for a surgical procedure. It's an evaluation. Then at the end of the evaluation, there could be the surgeon who says, I'm really sorry, I can't do anything for you. Or there could be the patient who says, I'm really sorry, I don't want anything done, and I will keep my seizure as they are.
Thank you. That's an excellent answer. And just to say, we've got 4 more questions now. I think we might just be able to get through those. But just to say, unfortunately, we may run out of time for more questions, but let's see how we get on. So the next one, and I'm sure a lot of people are thinking this, is about referral pathways, access to LITT. So this person says, how do you become part of an epilepsy program to find out about your cavernoma and epilepsy and LITT? I have multiple cavernoma and drug-resistant epilepsy since 2012.
So within our service, so this is a very good question, and I would say that the services sometimes they are disjointed, and you will have big hospital and big epilepsy services that will tend to cluster the cavernoma treatment related with epilepsy to a single group of individuals, neurologist, neurosurgeon, and smaller unit that will tend to treat the cavernoma as a general pathology. In our center, what we tend to do is to see the cavernoma in conjunction with a neurologist if there is an epilepsy problem. Generally, my neurosurgical colleague cranial will tend to refer the patient to myself. I will see them jointly, and at that stage, there is an enrollment within the surgical epilepsy program. I think there should be, in a first instance, a referral to a neurologist with an interest in epilepsy, or sometimes a neurosurgeon with an interest in epilepsy, and that will lead to the enrollment within a neurosurgical program, an epilepsy program, and the beginning of the investigation, which I would emphasize sometimes are time-consuming, and it will take up to 6 months just to get an answer regarding where the seizures are coming. Is the cavernoma generating the seizure, yes or no?
And it's helpful for people to have a sense of timeframes. And just to say in the chat, my colleague Batul has shared the links to the Wharton Centre and King's, which are the 2 centres for LITT. But as Mr. Farah has shared, there is a particular referral pathway for that. There's particular criterion, but we've shared those in the chat. So the next question. I discovered I had a single left parietal lobe cavernoma causing epilepsy, and it's 2.5 centimetres. I'm on 2 medications, and it's currently controlled for the last 9 months. I'm reluctant for neurosurgery, but I want to know my next steps to discuss options with my neurologist in the future, and when surgery should be considered LITT or otherwise. You mentioned an epilepsy program. I don't believe I'm on one at the moment. Could you tell me more?
Okay. The seizures are controlled on medication. And the first question that the patient should ask themselves is, are they happy with the control of the seizure, yes or no? So are they happy to be on one single medication, seizure is controlled, the cavernoma is not growing in size? If they are happy, they don't necessarily need to be enrolled within an epilepsy program. If they would like to consider a surgical resection, then in that case, they should ask to be referred to a neurologist with an interest in epilepsy or to a neurosurgeon with an interest in cavernoma and epilepsy.
Excellent, thank you. So last 2 questions, I think we can squeeze them both in. Is there a link between stress and anxiety and epilepsy and seizures?
I would say yes, and it's possible. There is definitely a link. Then there are the so-called non-epileptic attack, in which the patient feels that they are epilepsy, but in reality is the anxiety itself that is causing what is perceived as epilepsy by the patient. In other words, there are non-epileptic attack and epileptic attack. There are patients with epilepsy, with drug-resistant epilepsy, which will have recorded attack, in which it's possible to see the abnormality on the EEG, and then they will press the button during the monitoring, and they feel that they had an epileptic attack, but then in reality there is no changes on the EEG, and that can be driven by stress. On the other hand, stress can actually induce seizure at times.
Thank you. And so the last question. My cavernoma is in the left temporal lobe, and I occasionally have speech issues, even with taking lamotrigine 250 milligrams twice a day. Even with this medication, is it likely to be a focal seizure or a separate issue that is causing the speech problems? Thank you.
More likely is the cavernoma which is causing the speech problem. I will assume that the patient is right-handed and that the left temporal lobe will be the dominant temporal lobe, and the speech issue could be a very small focal seizure which is irritating the speech area nearby the cavernoma itself, and yes, I would consider that related, although I will need to have a look at the images, and she will need to have an EEG in order to define that. But yes, if it's a dominant temporal lobe, speech problems are classical within temporal lobe epilepsy in a dominant hemisphere.
Mr. Farah, we've got through all the questions and it's absolutely bang on 8:30, which is marvellous. I've learned so much, and I can see through the number of questions we've had that our members have really, really valued having you come and talk to us today. It's been so informative. So I just want to say a huge thank you for kindly taking the time to speak with us today.